Should we start?
Let's do it.
Okay. So my name is Bob Centaur, for those of you who don't know who I am. I will be the quote expert tonight. We have a new intern and a second-year resident who will really be the experts, and I'll just try to help them along a little bit. The main idea here is that everybody will learn a lot. If you want to see it again, it'll be posted on YouTube, and you can go back and look at the first two episodes were acid-based, and we'll do some more acid-based later on. And next week will be our first hematology one, and I think you're absolutely going to adore Dr. Jory May. She's so good, and she just joined our faculty. She was a student, a resident, a chief resident, and hem-onc fellow, and she's doing benign hematology, and she's just one of the best teachers you've ever seen, and she just loves hematology. So I think there'll be a lot to learn. We're going to try to give you a lot of variety here on Tuesday nights, so that over the course of the year, you'll be so much better at interpreting labs, we hope. Stephen, take it away.
Yeah, so I just to introduce everyone on the panel before we begin. So I'm Stephen Alon. I'm one of the chiefs here at UAB. I'm joined by a couple of the other chiefs, Sean Carter and Seema Kumar. We're going to be presenting the case, running the whiteboard, and making sure we keep an eye on the chat. So if you guys have questions, please bring them to us. I want to also let the discussants introduce themselves, Glenn and Zach, if you don't mind.
All right, hey, I'm Glenn. I'm a PGY2 at UAB.
And I'm Zach. I'm one of the new interns at UAB.
Awesome. Thank you guys for being brave enough to join us. We really appreciate hearing your thought process. So before we begin, we're just going to do a quick review of last week's case, specifically the approach to anion gap acidosis. And I'm going to let Dr. Centaur go over that.
So I believe that we've posted this on, have we posted this on Twitter, Sean?
Yeah, we have.
Okay. So the way that I teach increased anion gap acidosis is KILL-U. And the reason I do that is because it breaks down to categories much better than mud piles, which has no categories and makes no sense. And I'm the only person here who ever saw peraldehyde used. And the last time I saw it used was during my internship year in 1976. So the K stands for the ketoacidoses, and we went over those. I did do some reading on alcoholic ketoacidosis today. It's much less common, but it can be very, very severe. And you probably should check a beta hydroxybutyrate if you suspect it, because it has a very high beta hydroxybutyrate and often has a very low acetoacetate. A negative urine does not rule out alcoholic ketoacidosis. The ingestions are always important. The ethylene glycol and methanol actually cause an anion gap acidosis. Ethanol sort of gives you an increased osm gap, but it doesn't really cause an acidosis unless it causes alcoholic ketoacidosis. For those of you who were on last week, we had a salicylate case with the peculiarities of that. Acetaminophen, iron, INH are all very unusual, but something to have in your back pocket if you're really frustrated. Lactic acidosis is probably what most people see the most of, because anytime you're in anaerobic metabolism, so if you're in the ICU, you're going to definitely have a lot of people who have lactic acidosis. And we talked about dying gut, dying limb, et cetera, et cetera. And then we talked about type B, which is tumors and medications. And then we talked a little bit about the D-lactic acidosis, or the short gut syndrome. And the final thing is in uremia, and this predominantly is either stage 4 or stage 5 kidney disease. And most of the time, when you see an anion gap acidosis from either CKD or acute kidney injury, you see a very elevated phosphate. It's phosphates and sulfates, but phosphate is the clue. So if you see a phosphate of 8 and they have an anion gap of 20, it's probably the phosphate. And then we did go over the Winner's formula for compensation metabolic acidosis, and that was useful in sorting out last week's case, and I'm sure it'll be useful in a future case. I hope that's a reasonable summary. If anybody has any questions about that afterwards, please refer them either to my Twitter account or to Unremarkable Labs. I follow Unremarkable Labs also, and we'll be glad to answer any questions. So let's get on with the show.
Let's do it. So Glenn and Zach, I'm going to give you a little bit of HPI and labs, and then I'm going to swing it to you. So this case is a 42-year-old woman with SLE who comes in with 2 weeks of nausea and vomiting. So her BMP, sodium 125, K 4.8, chloride 89, bicarb 22, BUN 16, creatinine 1.2, and glucose is 128. So when you see these labs, I'm going to ask Zach to start us off, and you hear that history. What kinds of things does that bring to your mind? Tell us what you're thinking.
Zach, are you muted?
There we go. Better? Yeah, okay. So the first thing I noticed on those labs was the sodium of 125, which is much the normal limits of sodium. And that with the 2 weeks of nausea and vomiting, it makes me think there could be some extrarenal sodium loss. It's based off of that sodium in the pertinent chief complaint.
Okay, so Glenn, you're now an upper level. It's pretty scary, huh?
Yeah.
So, what do you want to add to what Zach had to say, or reinforce what Zach had to say?
Yeah, I agree. I agree with this thought process. So, I mean, SLE is complicated. That certainly can cause us to go down a lot of avenues here. So we're going to have to be fairly systematic, I imagine, to get to the right answer here. Of course, kind of the first thing in your algorithm is to make sure that the sodium that you're looking at is actually what it is. Her glucose is 128. So, we don't have to do a correction for her glucose. I think this is a real sodium of 125. I do see a sort of borderline low chloride there. Usually when I see that, I kind of start to lean towards a hypovolemia, but I'm going to need some more information.
So,
before we can make that call. I also see that, her renal function is probably not terribly impaired, but we don't really know what her baseline is.
right. So you would like to know the baseline. 1.2 is probably a little elevated for a 42-year-old woman, probably a little bit, and her BUN is up a little bit. How are we going to determine that this is true hyponatremia as opposed to pseudo-hyponatremia? Have you thought through that, Zach?
Yeah, we could check a serum osmolarity.
Thank you. That'd be a really good thing to do. And that's probably always a good step just to make sure you're not missing something. So when I think about hyponatremia, the first step that I always do is it real? Let's go ahead and get a serum osm. And obviously we're going to get a urine osm at the same time. Let me give you paraphrase a sentence from Acid, Base, and Electrolytes Made Ridiculously Simple, which is not a simple book at all. all disorders of serum sodium are problems of water handling. Have you heard that sentence before? I say it a lot. And so this means the patient is taking in water and is not excreting free water. So as we go through the differential, we're going to be trying to figure out why this patient is not getting rid of free water. Now, what in this lab, there's something that really surprises me in a patient with 2 weeks of nausea and vomiting. There's two lab tests here that pretty much shocked me. Do you have any idea what I'm talking about, Zach?
Yeah, with vomiting, I'd expect their potassium to be lower, and I'd probably expect them to be more alkalotic.
Absolutely. And so that doesn't fit with the history, and so we're going to need much more information. So do you guys have a choice of asking for more history or asking for more labs? Glenn, what do you want to do?
Well, let's get a little more history.
Okay. So Stephen has the history, so go ahead and ask him questions.
Yeah, Glenn, so you get 2 questions, so you got to make them count.
All right. Does this patient take steroids, or is she supposed to be?
Yes, she does. She's been taking them because she's was diagnosed with pleuritis a couple months ago.
Okay, Glenn, explain. That's a brilliant question. Just in case everybody in the audience doesn't know why, tell them why you asked that question.
Well, she has hyponatremia and hyperkalemia. Well, I guess you could say relative hyperkalemia, or inappropriately normal potassium. And when I see that, I tend to think about adrenal insufficiency, particularly the mineralocorticoids, and a patient with lupus very likely could be on chronic steroids, and if she had discontinued those for some reason, she could have an adrenal insufficiency.
So I love your thought process. What I'm not sure about is what steroid. So I'd expect her to have glucocorticoid to have the risk of having glucocorticoid deficiency. But usually when we give oral steroids, we don't get mineralocorticoid deficiency, right? Because we're given glucocorticoids. So I'm trying to resolve that. And I love the question. I love the thought process, but I'm trying to put that together as a possibility. Is there, if this ends up being an adrenal problem, is there something else going on other than just the being on glucocorticoids and perhaps having some kind of stress and needing more steroids than she's getting? So I think we need to keep that up in the air because of the higher potassium. Now, that may just be it, but I worry about it. You get another question.
Oh, man. All right. Well,
Well, if you're out, then Zach can come up with a couple questions.
let's get Zach in here.
Okay.
Yeah, I guess I'd want to know if she's had any recent medication changes, like she started anything new.
So let's expand that question, Zach. Why don't you just ask for a medication list? Always good in this situation to ask for a full medication list. There's advice for an intern. Always look at the entire medication list because a large percentage of the time the medications are the problem. What medication might she be on with lupus that would give us that high potassium and that lower bicarb? I'll give you a clue. What if she had proteinuria from her lupus?
An ACE inhibitor?
Yeah, You know, that's why we need a medication list. Is she on an ACE inhibitor for some reason, or does she have severe hypertension? Is she on spironolactone? And that would be good information here, right? So can we have a medication list?
Yeah, absolutely. So you guys are right on the money that she is on an ACE. She's on lisinopril. She is also on amlodipine, and then takes fluoxetine for depression.
So Glenn, how does that medication list help you?
Let's give me the medication list again real quick.
Yeah.
It was lisinopril, amlodipine, and fluoxetine.
All right. So, you know, the lisinopril certainly adds to the, you know, potential causes of elevated potassium. Amlodipine probably not gonna be very significant here. I'm not really sure about the fluoxetine either.
Okay. Zach, do you have any idea about the fluoxetine?
Other than what was put up there, I think it's one of the SSRIs are known to maybe cause like an SIADH, so it could potentially help explain this hyponatremia.
So that is a very, very important point. You're going to see hyponatremia in clinic patients, especially after you start them on an SSRI. And we'll try to get to that question later on. When do you get worried about the hyponatremia? But we always have to have it in the back of our mind. So that's really a good, good thought. So the medication list has helped us. Okay, so we decided we're going to order a serum osm and a urine osm. We're going to order anything else.
Well, let's get some urine electrolytes. Let's get a urine sodium at least.
And how's that going to help you?
Well, it might help us differentiate between hypovolemia. It might help us point just toward SIDH, depending if it's high or low.
Okay.
Yeah, I see ADH state, which basically summarizes what I'm trying to say there in the comments.
Right. And we'll get to that. So we send off the labs, but in the meantime, we're going to examine the patient. So let's try to focus our physical exam. What are we trying to decide with our physical exam?
Volume status.
How good are we at how good are we at determining volume status?
We're not good.
At least according to the JAMA article that looked at this, at 15% we're really good. At 15% down, and less than that, it's not really quite as good. How else might you do that at the bedside? Might get an idea in someone who seems to be, I mean, she has lupus, but she doesn't have a lot of the no history that we were aware of heart disease or anything like that. So what else might you do at the bedside?
Well, we might grab an ultrasound and look at her IVC.
I think that's really useful, and it's helped me with a few patients. I haven't learned it myself. I think I'm too old to figure this out, but the residents are also good at it that they help me out. And I think that might be a way to assess that maybe you really are volume down while you're waiting for these labs to come back. I think those are the key things. Are there other questions we want to ask her? I mean, we have 2 weeks of nausea and vomiting, but that's very non-specific. So Zach, this patient's admitted to you, and that's all the resident tells you when you go down and talk to them. What questions do you want to ask about the nausea and vomiting?
I mean, it's been going on for 2 weeks. Maybe if it's associated with anything particular, like any particular foods. Or,
okay, so let's just think about this. So this is really, really important to learn at the beginning of your internship. When I see nausea and vomiting, the first thing I want to know is how much. And he just said 2 weeks of nausea and vomiting, but is that vomiting every other day, or is that vomiting all the time? Those types of questions can really help you. So trying to get the granularity of what the patient's talking about can be very, very helpful in better understanding what's going on. You can certainly get hyponatremia just from vomiting. We don't need anything else. If you're vomiting and trying to get fluids back, you'll get in enough fluids. And we might also ask about diarrhea. Has she ever had this before? Those types of things. That makes sense, Zach? Okay, Stephen, can you help us with that?
Yeah. So she has been vomiting every day, at least 2 or 3 times a day. Doesn't seem to be associated with food. There's no blood in her vomit. There's no diarrhea. And looking at the chat, a few people have been asking about pregnancy tests. She at least does not think that she's pregnant. She's not been sexually active in the past few months.
Okay. So we asked for a serum osm and a urine osm, so maybe we could get that, and then I'll start to go through the schema for how I think about it.
Yeah. So her serum osm is 273, and her urine osm is 417.
Okay. Glenn, what do you want to do with those two numbers?
All right. So her urine osm is elevated relative to her serum osm. So, I mean, that tells us that ADH is activated.
Right. Now we just have to figure out why she has ADH activated.
Right.
So, Sean, do you want to bring up the schema? We actually prepared this in advance. So this is the way that I think about hyponatremia when the patient just comes in. We first evaluated for pseudohyponatremia. We've ruled that out as true hyponatremia. Then we're going to look at volume status. We're still not sure if the patient is hypovolemic. Would hypovolemia explain her numbers? What do you think, Zach? So does hypovolemia make you produce ADH?
Yes.
Absolutely. So that's exactly the numbers you would expect for hypovolemia.
Dr. Centaur, if it was hypovolemia, let's say just from her vomiting, in that case, would you call it volume contraction versus hyponatremia? And can you expound on that vocabulary difference?
Yeah, so hypovolemia and volume contraction are the same thing. It's a decreased intravascular volume. And that's really easy to treat with saline, just saline or lactated ringers. But both will work very well. Now you have to figure out why she has nausea and vomiting so it doesn't come back. Let's go to the right side of the bottom, the hypovolemic states, the edema states. Did she have any edema, Stephen?
She did not.
Okay. So this is mostly heart failure, left-sided heart failure, and cirrhosis. It can happen nephrotic syndrome, but it's mostly heart failure and cirrhosis. Here's the important things. If a patient with significant heart failure, decreased ejection fraction heart failure, comes in with hyponatremia, they have a horrible prognosis. That was known when I was an intern in the 70s. It's been known for a long, long time. We didn't really understand that hyponatremia was a major risk for cirrhosis. I think it was about 10 years ago or so. There was a wonderful article in the New England Journal, and that's when we switched from the MELD score to the MELD NA score. Because being hyponatremic with people with the same MELD score, much higher mortality. So, but she's not hypervolemic. If we have time, we can come back and explain why people with hypervolemia and edema get hyponatremia. I think we have time. Do we have time, Sean? Stephen thinks that we have time. So there's this wonderful article by Robert Schreier, and I sent the chiefs the references, and they could pull the reference out and put in the chat if people are interested. And it was when I was in medical school, and I think they still teach this. They teach you that in heart failure and cirrhosis, you have ineffective intravascular volume. Have y'all heard that expression before? That was like the stupidest expression. I couldn't understand what the heck they meant, because if you measure the plasma volume, it's actually increased. Until I read Schreier's article where he explained that at least in heart failure and cirrhosis, that the intra-arterial volume is decreased and the venous volume is increased. And so there's a total increase in plasma volume, but what they mean by ineffective is the arterial volume is down. And when the arterial volume is down, that stimulates ADH. And decreased arterial volume is a very bad sign in both heart failure and cirrhosis. Okay, so that's the Demonis states. So can we assume that this patient looked euvolemic, Stephen?
She did.
Okay, so if she's euvolemic, the next thing you do is you check the urine osms, which we did. And if she'd had a very low urine osm, then we'd be thinking about primary polydipsia, beer potomania, tea and toast diet. But she doesn't have that, so we don't have to worry about that. An increased urine osm like she has means ADH is present. Now, before I go down that road, I always have to think about four things. And those four things, we've already mentioned one of them. You just have to memorize these. There's two endocrine ones. So Glenn already gave us one, right, Glenn?
Yeah, I think so. Just trying to remember what it was. So we got adrenal insufficiency.
Right, adrenal insufficiency. Do either one of y'all know what the other endocrine one is?
Hypothyroidism.
Right, so hypothyroidism probably decreases cardiac functions and stimulates ADH in that way. It's not exactly clear why. Do you understand why thiazides can cause hyponatremia? So this is Zach, when you're in clinic, this is the magic thing. You start someone on an SSRI and a thiazide, and they come back with a sodium of 128, and now you're in trouble. So don't start both of those at the same time. So why do thiazides cause hyponatremia? The chat's on fire, by the way. So Glenn, do you have any idea? Good, let's go back to renal physiology. I hope nobody breaks out in hives. Sometimes people get an anamnestic response when we talk about renal physiology. Do you remember where thiazides work in the kidney?
Yeah, they act at the distal convoluted tubule.
And what's the function of the distal convoluted tubule?
To reabsorb sodium.
Sodium and chloride. So essentially, to make dilute urine. It's also called the diluting segment. So if you're on thiazides, you cannot maximally dilute your urine. So let's say you're drinking quite a bit of beer, and otherwise you're getting rid of all of it, and then somebody puts you on a thiazide because you're hypertensive. Now you can't put out as much free water, and you become hyponatremic. So having the beer potomania, which we could talk about another time, and having a thiazide prevents you from maximally diluting your urine in a situation where you have to maximally dilute it. But it should not give you a urine osms over 400. And then the last one is chronic kidney disease. And again, this usually doesn't happen until about late stage 3B or stage 4. So as you get further down the road of chronic kidney disease, you start to have a fixed urine output. And the reason for that is you start to wash out the countercurrent mechanism. So if we all have normal renal function, maybe somebody doesn't, but let's say we have normal renal function, we can really concentrate our urine, we can really dilute it. Nobody can explain the countercurrent mechanism. I predict no one in this room can explain the countercurrent mechanism. In this Zoom, there's not a room, it's a Zoom. But it's flow dependent. That's the one thing I remember from first year physiology, is that it's flow dependent. So if you increase flow, you have to wash out some of that concentrating ability. And so you can't concentrate as much and you can't dilute as much. And towards the end, before you get to end stage kidney disease, you have a very narrow range. So what happens is that you have no ability to adjust to differing circumstances with significant chronic kidney disease because you can't dilute well enough. Does that make sense? So this patient doesn't have enough chronic kidney disease for us to worry about that. May well have some kidney disease. We didn't get a urinalysis. It'd be interesting to know a urine protein creatinine. Are we dealing with someone who has lupus nephritis of some kind? Did you have that by any chance, Stephen?
Yeah, she had a UA without, not a UPCR, but her UA just had 1+ protein.
Yeah. So what was and her specific gravity should have been elevated, right?
Yeah, it was 1.021.
Okay. Zach, do you understand that? The urine specific gravity? Yeah, explain it. We have some students on here who might not understand it as well as you.
Yeah, so specific gravity is essentially going to give you an idea of how, I guess, dense the urine would be. So specific gravity is going to indicate a much more dense, much more, or a much less diluted urine as opposed to one with lower specific gravity.
Do you know what the cutoff is between dilute and concentrated? You're about to learn. You're about to learn. Glenn, do you know?
1010.
1010, exactly. So somewhere between 1.008 and 1.010, that's what we call isothostanuric. And so 1.020 is clearly concentrated urine. And if we got that back before the urinosms, most of the time that would predict that the patient's volume contracted, or at least has concentrated urine. It totally does not work if the patient just got a CT angiogram, because that dye will give you a ridiculously high urinosm. So if she, with that being concentrated urine, you'd expect the protein to be higher. She probably has a little renal disease, but not much. Okay, so let's think about the physiology of ADH. What are the normal stimuli for ADH?
So the biggest one is hypovolemia. That's the most potent.
Right.
Followed by hypotonicity. Another big one is, I don't know how big it is, but pain.
Right. That's actually a really big one. You'll notice a lot of your patients come in with mild hyponatremia that we're not going to do anything about, we're going to ignore. So one of the ways I remember this is the post-op state, because you have pain, you often are volume down. Any stress can do it. And then a number of drugs, opiates can do it. SSRIs can do it. There's two organs that, when they're disturbed, often have increased ADH.
Let Zach take that one.
Yeah, the first one that comes to mind, I would guess is the lung.
Absolutely, that's spot on, and you can see it with almost any lung problem. You see it with pneumonias, you see it with TB, you see it with histo. I mean, you see it with pleural effusions. So yeah, if you have lung disease, try to treat the lung disease before you get too excited. And what's the other organ? And this should be straightforward.
I think it's the brain.
Yeah.
It is the brain. It is the brain. So you'll see it after strokes. You'll see it with brain abscesses. You'll see it with subarachnoid hemorrhage. So with I call those understandable understandable SIDH. So Sabina mentions renal salt wasting that is sometimes associated with brain disease. I just read an article on this today that's in the Clinical Journal of the Association of the American Society of Nephrology, CGASN, and that is one of the most debated topics in hyponatremia. And I usually don't even cover it, but I noticed that somebody put it in the chat. It's unclear whether it's cerebral salt wasting is a really important common thing, but you do get a lot of ADH. And then the absolute syndrome of SIDH is what? The one that's so hard to treat.
Jack?
We're talking something paraneoplastic or?
Yeah, absolutely.
Yeah.
So a variety of cancers can do that. And that's really hard to treat. Okay, so let's get back to our patient. So now we have this patient who's vomiting, who's on all these meds. You mentioned, Stephen, you gave us the meds, but you said the patient was on steroids, but you didn't give us a steroid.
I apologize. She's on prednisone.
How much?
She's on 40.
Okay. And so what's the next question you want to ask, Glenn? Teach Zach here.
Is she still taking her prednisone?
Exactly. It's such an obvious question, but always find out whether or not for some reason they've stopped the medication.
Yeah, so she's still taking it. She's actually been on a steroid taper for about a month now for her pleuritis.
So the pleuritis itself could have caused the caused the hyponatremia. Is the pleuritis doing better with the prednisone?
It is.
Okay, so what additional lab tests do you want to order? And why?
Yeah, I'd like some urine electrolytes. To get a urine sodium, certainly. And, since this is a patient with vomiting as well as other things going on, let's get a urine chloride as well.
So how are those going to help you?
So if the urine sodium is low, that might point me towards like GI losses, could be like diarrhea, things like that. If the urine sodium is high, but the chloride is low, I might be more leaning towards like a vomiting etiology here. But if the and then if the urine sodium and the urine chloride were both high, I might be leaning more towards like a renal insufficiency picture. But definitely urine sodium is going to be high if she has SIDH.
So just for grins, I would probably also get a urine potassium. And I'm gonna argue, just for the sake of argument, that the urine sodium will not help us because of one of the drugs she's on.
Okay.
Because she's on lisinopril.
Yeah.
And so she should have a low urine potassium and a high urine sodium, even if she's volume contracted. And so therefore the idea of a chloride is going to be really helpful. because that won't affect the chloride. So if I was going to get the urine sodium chloride, I'd get a potassium also, because that potassium of 4.8 is so striking. Do you want to get anything else?
Well, I guess for the sake of working up the hyponatremia, I think that'd be a good place to go right now. Zach, what do you think?
I guess getting a TSH on her, I mean, if we're going to completely work this up.
I have diagnosed one that surprised the hell out of me once. And that was really the cause.
And cortisol's not going to be helpful when she's on prednisone.
Right. So the cortisol is going to be depressed because of the prednisone. So we're just going to have to decide that empirically.
Yeah.
She's not on thiazide, so we don't have to worry about that. Do you want to start treating her?
We could give her some normal saline.
Okay. I think normal saline would be a very reasonable thing. What do you think will happen when we give her normal saline?
Well, Zach, what do you think will happen if we give her normal saline?
I mean, if this is SIADH, I don't think it'll help very much. So if in that case, we do a fluid restriction, if anything, but that's kind of dicey with 2 weeks of nausea and vomiting.
Yeah, so
I guess
here's the question. When does giving saline make things worse?
when the ADH is constitutively active and not physiologically active.
And the times I've seen it several times, is when the urine osmoles are in the 600-700 range, usually not at 417. If you gave saline and the sodium went down, that would mean that you have a really strong ADH effect. Now, she has a good reason for a strong ADH effect just with the fluoxetine. Could the nausea and vomiting have anything to do with the sodium of 125? So the question is, which came first?
It's a good point. Is this symptomatic hyponatremia?
Right. And that we don't know. Now, there's another situation where giving saline could really hurt the patient, other than SIADH. Do you know what that is? So that would be someone who has beer potomania or primary polydipsia and has a very low sodium. So at 125, I'm not really worried about increasing the sodium too fast. At 115, I am. At 105, I am, especially if they're very symptomatic. And what I mean by very symptomatic is seizures, altered mental status, things like that. So I don't mind giving a liter of saline here and rechecking and seeing how things go. This looks a lot like volume contraction. It sounds a lot like volume contraction. Could be made worse by the fluoxetine. So we have to think about that. It'd be nice to know, do we know what her old creatinine and BUN were?
Yeah, this seems to be about her baseline.
Okay. So she's not that volume contracted. So we went ahead and ordered all this stuff, and why don't you tell us what happened?
Yeah, so I'll give you all the labs and you can kind of help us work through it. So her urine sodium was 52. We did not have a urine chloride. You guys had asked for a TSH, that was 3.5. They had gotten a random cortisol down in the ED, and that was 4.1. She got 2 liters fluid while she was in the emergency department, 2 liters of normal saline, and her repeat sodium was 126.
So what does that suggest to us? We have an intern and a second year. I guess the intern has to go first and the second year has to teach them. Of course, the intern can always just turn to the second year and say, I need your help.
I mean, the fact that it didn't improve very much with the normal saline, you know, kind of, well, I don't know. Yeah, Glenn, why don't you help me out?
Yeah, so I guess I don't know how long they waited to recheck that sodium. That can affect it. But yeah, if she was hypovolemic and her ADH, you know, was turned on, then repleting her volume should have turned off the ADH, and her sodium should have started to come up. So yeah, I mean, the sodium doesn't have to necessarily go down for it to, but we would have expected it to go up more than 1 point if this was just truly hypovolemia.
So how long had she been on the fluoxetine?
She'd been on it for about 2 years.
So this looks like ADH to me because it didn't get better. It didn't get worse because her urine osms are 417. They're not 600. And when I give my talk, and I'm going to give a whole talk on hyponatremia, and I'll explain why that happens. Then the vomiting itself, the nausea and vomiting increases ADH also. The patient does not seem to be profoundly volume contracted. So I try to improve her nausea and vomiting, hold her fluoxetine, and see how she does over the next. She's not getting into trouble. She's at 126. She's not in trouble. We just have to watch her and see what happens. We'll go ahead and get a chest X-ray, do all those other things, and try to figure out if her nausea and vomiting gets better over time.
Yeah, so I'll kind of take us through all of that. So she got a chest X-ray, which was unremarkable. Lung fields were clear. They did hold her fluoxetine when she came into the hospital, and after 2 or 3 days in the hospital, she was still throwing up, and her sodium hadn't really changed. So they did an ACTH stim test, and that showed, let me pull it up, a peak cortisol of 8, and her ACTH level at 8 a.m. was 12 picograms per milliliter with a reference range of 20 to 52.
So now what, Zach? What was that last number you gave us?
Yeah.
Oh, her ACTH level at 8 a.m. was 12, and the reference range for that is 20 to 52.
Well, yeah, I guess that's lower than expected, which would make me think that, well, actually, I feel like I'd kind of expect that if she's chronically on cortisol anyway. I'd expect it to be lower than the normal limit.
This is why we're going to have a couple of endocrinology ones to be 100% sure about this. But this is the way I'm thinking through this, and I think we're on the same page, Zach. If you're on a high dose of prednisone, that should suppress ACTH and suppress the body making cortisol. If you're suppressing the body making cortisol, then but the problem is that prednisone is measured as cortisol. There's only one glucocorticoid that is not measured as cortisol. Which one's that? So,
wait, are you talking about dexamethasone?
Dexamethasone,
I guess. Okay.
Right. So if somebody comes in, have you had night floats yet, Zach? When you're on night float and you're covering somebody, and you think perhaps they're having adrenal crisis, draw a random cortisol and give them dexamethasone, because that will not interfere with the ACTH stimulation test the next day. Now, I guess the point here, so I'm going to try to reason through this. And Glenn, you tell me if my reasoning makes sense. We're still giving 40 prednisone, right?
Yes.
40 prednisone should have a pretty high cortisol level, because prednisone gets broken down to cortisol, and this is still really low. So there's suppression there. Why is there, I mean, there's suppression because of the prednisone, but why is it not a high level? And why is the ACTH a problem? So I think we have to worry about, is there a central problem? Now, the TSH is okay, so we haven't knocked out the entire pituitary. I wonder whether we should be giving even, I mean, it seems like 40 prednisone should be stress dose steroids. So I'm going to call for help.
Yeah.
I'm not 100% sure where to go now.
And we did the same. So we asked our local expert endocrinologist, and they weighed in, and they brought up the same point that you did, Dr. Centaur, that it's surprising that her cortisol levels are so low with being on prednisone, and that suggests maybe there could be a central process. So when we went back in her history, it was revealed that she was previously on as high as 100 milligrams of prednisone a day, and had been slowly tapering over the past couple of months. And once she got down to the 40 milligram dose is when her symptoms started. So they felt like the diagnosis was secondary adrenal insufficiency just during her prednisone taper. So we gave her a higher dose. We went back up to 80, and her nausea and vomiting slowly improved and her sodium normalized. And so the endocrinologist said that confirmed the diagnosis of secondary adrenal insufficiency.
That is really wild, and the urine sodium doesn't help us because of the lisinopril, right?
Mm-hmm.
So I think that's an important takeaway, is that in that situation, urine chloride would have been more helpful than urine sodium. It's sort of like anybody who's vomiting, it's probably worthwhile to go ahead and get a urine chloride. But if I'm going to get urine lyse, I get all three of them, because I might want to use them afterwards. Okay, so Zach, give me the two most important things that you got out of this.
Most important to me, or like subjective or objectively most important? Because the
most important to you. This is all about, what did you learn?
The cortisol prednisone thing was really helpful, and knowing that somebody on prednisone should have high cortisol levels because of the metabolite, and then knowing the these 10-10, easy to remember, so I'll lock that away for good.
Great. What about you, Glenn?
Yeah, this is a realistic case where your nice tidy algorithms are just washed away, and you really have to dig in and understand, what pieces of information are actually useful to you. The urine sodium was my go-to, but I can't use that here, and so we really had to think harder about it. But yeah, just knowing how to deviate from your sort of your fixed algorithm for problems like this.
Seem, are any issues from the chat room?
Well, it's been on fire. So certainly we can get you to give us some thoughts and put them on our Twitter as well, and reiterate, because I'm sure we'll come back to this schema multiple times. So I can do a quick summary of just some extra
Great.
points that we've talked about. Thank you, Glenn and Zach. I think you guys probably reiterated the most important things that we all got out of this. But just so start with just a couple of quick points that we had talked about. I'm probably going to butcher this statement, so Dr. Santor, you can correct me, but all disorders of sodium are problems of water handling.
That is exactly right.
Okay, great. Well, we'll all get that tattooed when it's all over. That'll be our tagline. So we can stop right there with that statement, but I'll give you a few more. So when you have hyponatremia, the first step is that you want to distinguish true versus real. So you're going to get your serum osms. We talked about specific gravity, and the number that we need to remember is 10-10, and that's where our general line is for dilute versus concentrated urine. And don't forget that if they've just gotten contrast, that's going to change your UA value. So that's a really great pearl, because again, a lot of times when we're getting the call, patient's been in the ER for a while, and very often the UA is coming after they've already had some imaging study. We talked about normal stimuli for ADH. So a good, easy way that Dr. Santor mentioned was thinking about a post-op state. So pain, them being volume down, or really any stressor on the body. Think about drugs like opiates and SSRIs. And then you always want to remember your lungs and your brain. And then finally, as far as when you're giving saline, you want to be really cautious when you're thinking about SIADH, pheropotomania, and primary polydipsia. Two quick explanations that we went into. So why do you get hyponatremia in edematous states? We'll be sure to include that article on our Twitter and the YouTube. But essentially, you have decreased intra-arterial volume. Your venous volume's increased, so you have a total increase in your plasma volume, but because the arterial volume is down, that stimulates ADH. And then the second explanation was about why do thiazides cause hyponatremia? So your thiazides are working at the distal convoluted tubule, the diluting segment, which functions to reabsorb sodium and chloride and make dilute urine. So if you're on a thiazide, you're not going to maximally dilate your urine. And we're thinking about those patients who come in, maybe they're drinkers, they drink beer, you're suddenly on a thiazide, and now the next time that you're seeing them, they're hyponatremic. And finally, we have med students, interns on here, so some really great pearls, especially for the beginning of the year. Remember that it's really tough to determine volume status, and per the study we mentioned that unless it's more than 15%, it can be really tough. So we're going to go down, we're going to see our patient, put a probe on them and try to evaluate the IVC. Whenever you get that chief complaint of nausea, vomiting, or any other symptom for that matter, we really want to dig into the details. How much is our next question? We want all the nitty gritty. You're going to point to the cup at their bedside and say, how many of those did you fill up? So you're going to get all those details. And finally, probably the best pearl for intern year is get the whole med list. So I feel like the more questions and cases that we do, you'll find that it's that random supplement somebody's taking, one of those medicines that they don't even consider to be a medication because they've been on it for so long. So definitely really important to get that whole list.
So Seema, is it Monday that I'm doing noon conference?
Yes.
Yeah, so we're going to record that on Zoom. We could put this up as part of the Unremarkable Lab series. I'm actually going to do a sodium lecture for the UAB house staff on Monday with slides and everything. The chat, I see the chat says please put it up. So if that's okay, Seema, you don't have any problem because I said it was okay. So we always have already have several people who want that. And I have a lot of these schemes, and I'll go over them again, and a bunch of cases that make these points. So next week is hematology. And Stephen and Sean and Seema, y'all have been communicating with Jory about this?
We have.
Yeah, it'll be brilliant. I'm looking forward to it because I want to learn quite a bit. And Stephen, thanks for coming up with this case. This one was really, really tough.
I'm glad you guys enjoyed it.
It didn't make much sense at the end, but that's okay because you don't always know the right answer. And Glenn and Zach, Can we have a round of applause for Glenn and Zach? You see, if you go to the reaction button, you can put up the clapping sign. Thank you all, and I'm going to hang around and debrief with my co-conspirators. So if y'all could get off so that we can have our private debrief, we'd appreciate it. Thanks for being on, Travis. Everybody who is on, we really appreciate it.
Thanks, guys.